what is the leading cause of this for the patients to understand how they can make their chances better?
So commonly what we say is there could be a uterine factor, that means uterus could be involved. There could be age factor, there could be egg problem, there could be some systemic disorder like they form blood clotting.
When should they make that journey to a fertility specialist?
So if a couple has experienced 2 or more than 2 pregnancy losses, I think this is the time when they should go and visit a fertility specialist. Reason being, one is IVF, which can help them in achieving a good pregnancy outcome.
We know all the medical interventions, but what can a couple do from their side to actually help their pregnancy journey?
Most common things come like smoking, then having too many cups of tea or coffee like caffeine, if they are taking alcohol or any other thing. Then we must not forget our body is in the circadian rhythm with the sun. So many people have that kind of lifestyle. They wake up whole night, they sleep whole day. Even our hormones, they are in synchrony with the sun. So getting up on time, sleeping on time is very, very important. Then the stress. In today's time, there is everything available to us, but the stress is there.
Struggling with pregnancy loss or multiple failed IVF attempts can be overwhelming. But with the right guidance, you can take the right steps with confidence. Welcome to Fertility Tales powered by Nova IVF. I'm Simrat, your host. Today we have a special guest, Dr. Santosh Gupta, a senior fertility consultant at Nova IVF Koramangala, Bengaluru. With over 25 years of experience in obstetrics, gynaecology, and reproductive medicine, she has helped countless couples navigate fertility challenges and achieve successful pregnancies. In this episode, we'll discuss why miscarriages happen, when to seek medical help, and how treatments like IVF can improve your chances of a healthy pregnancy. If you or someone you know is on this journey, stay with us. This episode is packed with insights you won't want to miss. Welcome, Doctor. It's a pleasure to have you with us on the show.
It's a pleasure to be here.
Dr. Santosh, you have a career spanning over 25 years in obstetrics, gynaecology, and reproductive medicine. Let's start at the very beginning. What made you take this career path and how did you specialize in reproductive fertility medicine?
See, I did my MS in OBG 25 years back. Back then, even IVF was not available to the patient. It was available to select few cities. And similarly, training was also not available. I was a very meritorious and curious student. I always wanted to do that. But the trainings were not available. And they said, even if you learn, it is very expensive to practice IVF. But fortunately for me, life has given me a chance. My husband came and joined a premium institute in Bengaluru. I joined him. And after 1 year of struggle, I came to know there are many centers here who give proper training and degrees in reproductive medicine. So I was fortunate enough that my journey allows me to take training there. And it was a rigorous and very good training. And slowly I shifted towards the fertility.
As I understand, you moved to a new city to practice medicine. I'm sure it came with its own challenges. There must have been a language barrier also. How did you manage that? How did you pick up the language? Because IVF fertility is such a sensitive topic also. How were you able to adapt to the changes that you were?
See, when you need it, you will do it. One thing for sure, when we practice infertility, communication, empathy, and taking patient in confidence is very, very much necessary. Learning language after a certain age is not so easy. So I did my own homework, like how we used to learn things at childhood. So I picked up small sentences, did my homework. I communicated with the patient, my staff, people around. I must say people around in Bangalore are very, very helpful. So they helped me in learning the language.
So you were able to, I'm sure you were able to explain to the patients the entire process. And
I'm now very fluent in Kannada. I can converse it very well.
Then that's great, doctor. I mean, that takes a lot of courage and patience to learn a new language. Let's dive into the topic of recurrent pregnancy loss. It's a very rampant thing that women face in nowadays. What do you think is the primary cause of common miscarriage? Is something very common nowadays.
So, one thing we must understand is when we are talking about a single miscarriage or we are talking about the repeated miscarriage. So, one miscarriage is very common. So, if we are young, that means less than 35, 10 to 15% of all pregnancies will abort. 10 to 15%, it's not a less number. When people abort more than 2 times or 3 times, then where we label them as a recurrent pregnancy loss or recurrent miscarriage. And we must remember that with each abortion, your chances of abortion in subsequent pregnancy will increase. With your age, your chances of pregnancy loss will increase. So, younger you are, lesser is the pregnancy loss. After 35, pregnancy loss increases. At 40, almost it becomes 40%. So that's how it is. And we must not forget that any patient who comes with a history of abortion is a distressed patient.
That's true. And what's the guidance like? How do you break it down to them? If a couple comes with multiple miscarriages, what is the first course of treatment and what is the leading cause of this for the patients to understand how they can make their chances better?
So, see, it has many things. First, you have to talk to them empathetically. That is very, very much important. You have to give them hope. And there is a very fine line between false hope and telling them reality. So, you have to use guarded words and give them hope. Then takes over the science. So, you have to explain them causes of recurrent pregnancy losses. So, as anything, pregnancy is also made up of egg, sperm. Then there is a uterine factor, and then our body plays a role. So, one by one, you have to investigate the patient. So commonly, what we say is there could be a uterine factor, that means uterus could be involved. There could be age factor. There could be egg problem. There could be some systemic disorder like they form blood clotting. There could be antibodies. Our body prepares antibodies to fight against the disease, but sometimes same antibody starts damaging our own system. So this is known as autoimmune disorders. That means our own antibodies are fighting against us. So these also needs to be investigated. Then we must not forget that there is a slight contribution from male side as well. So sperm parameters, and we focus a lot on sperm DNA fragmentation index also. And the clotting factor like clotting time, bleeding count, all those we check. And couple karyotyping is also very important, the genetic test for the couple.
Ma'am, can you talk a little bit about couple chiropractic?
See, we all are made up of chromosomes. We have fixed set of chromosomes. So one, we have to see the chromosomal number. Few couples, they could be absolutely healthy. That means their basic chromosomal numbers are fine, but they may have extra twigs. Like there could be a translocation or extra twigs. So when a couple chromosome, like half mother will contribute, half set of chromosome comes from the father's side. So when they come together, they will arrange, then they will dissociate, then they will rearrange. So sometimes they get a fragment when one chromosome, that extra twig comes to the embryo. So it becomes a extra aneuploid embryo. That means they have an extra set of genetic information, which is also not correct. Or the other half will have lesser set of genetic information. So that is also not correct. So these can result into genetically abnormal embryo and can result into pregnancy failure or abortions.
Ma'am, how does IVF play a role here? I mean, for couples who have gone through repeated pregnancy losses, what is the connection between IVF as a solution to somebody who has gone through so much of repeated pregnancy loss?
So very interesting. See, IVF also, it's not about pregnancy positive. IVF helps you in getting a live birth. That is the aim of the IVF. So when we go back to the causes of abortion, apart from uterus, blood causes, environmental, lifestyle causes, one of the very most important causes about the genetic makeup of the embryo. You would be surprised to know, even in a younger patient, 50% of our well-formed embryos are genetically abnormal. That means they have either one set extra or one set lesser, which we call as aneuploid embryo. So these aneuploid or genetically abnormal embryo, either they do not implant, that means they result into an IVF failure, or if they implant, then they result into early pregnancy losses. Very rarely they can grow further, and we read about the few common genetic disorders like Down syndrome, Turner syndrome. So either they do not implant or they result into a pregnancy loss. So that's where IVF fail. Suppose if I don't want to have a abortion or reduce my pregnancy loss chances, then we create an embryo through IVF because the embryo is outside in the lab. If we go back again towards the structure of embryo, there's an inner cell mass and there's an outer cell mass. So from outer cell layer, we take out few cells and send it for genetic testing. So this is typically known as blastocyst biopsy or trophoectoderm biopsy. And we store that embryo in the center. These cells are analyzed for the genetic makeup of the embryo. In a very common language, we call PGTA or PGS, what most of the people know. So it is nothing but knowing your embryo genetically before really putting it. So either the result could come normal or it could come abnormal. So if the embryo is normal, the likelihood of that embryo resulting into a pregnancy and not aborting is very, very high.
That's really magical that you're able to, test an embryo before it is implanted to avoid genetic diseases. That's a really interesting factor. Can you talk a little bit more about the genetic testing aspect of what kind of anomalies can be detected with these genetic testings, and when should it be done? Is there a precursor to somebody who's had a past of genetic diseases in their family? Is that also a criteria for all of these genetic testings?
Yeah, there are. So what I was talking about is a PGTA. It's a generalized comprehensive test. See, as technology is improving, so earlier genetic testing was dedicated only to few chromosomes. Now there are advanced platform, NGS, they can read out almost everything. But these tests cannot read out specific disease. Suppose there is a specific genetic disorder in the family, then the workup is different. Those tests are PGTM, they are targeted, like somebody has thalassemia. So we have to do a workup. So if there is a family history of a known disorder, we can check embryos for those disorders.
How interesting.
And then if it is normal, we transfer it. The most commonly when we talk about abortions, so this genetic screening, that PGTA, basically we do it in patients who have repeated IVF failure in spite of putting good embryos, or those who have repeated abortion. And the most important group of patient which is emerging nowadays is advanced maternal age. When women are more than 35 years, or if they are approaching 40. See, because egg has a lot of role to play. As we age, 40 is not an age, but unfortunately, in terms of reproductive capability, we are old. Our egg is not able to do that much work, what it was supposed to. So chances of having a genetically abnormal embryo, it increases with the age. As I said, a young patient also will have 50% abnormal embryo, and nearly at 40 years of age, this percentage becomes 70 to 80%. So older women also, we advise these kind of tests.
And doctor, is there a connection between repeated pregnancy loss and repeated IVF failure?
Yeah, it sounds a little strange, but most of the causes are similar. So if you look at the repeated implantation failure or repeated IVF failure, again, it could be autoantibodies, which are present in our body. It could be genetic or acquired. Then there could be implantation failure because of abnormal embryos. Again, uterus. Uterus has to accept an embryo. So we always investigate uterus in detail if there is a implantation failure or a pregnancy loss. So uterus cavity can have adhesions inside. There could be a septum. There could be a genetic abnormality. There could be chronic infection, chronic endometritis. So these are the causes are almost similar. But a recurrent pregnancy loss patient is a very distressed patient. And it is very difficult sometimes to convince them because they are conceiving naturally.
Of course.
So why they need a assisted technology to help them? Because we can rule out these causes, and primarily because we can check the embryos and put it in a suitable environment. That's where the IVF helps.
Doctor, after facing so many miscarriages and repeated pregnancy losses, when do you think a couple should come to a fertility expert? When should they make that journey to a fertility specialist?
So if a couple has experienced 2 or more than 2 pregnancy losses, I think this is the time when they should go and visit a fertility specialist. Reason being, one is IVF, which can help them in achieving a good pregnancy outcome. And fertility specialists are not only IVF specialists, they are reproductive immunologists and reproductive endocrinologists as well. So IVF units are able to give wholesome treatment. And whenever a couple has 2 or more than 2 miscarriage, it's our duty to investigate into the detail. Before any investigation, you should look into the nature of miscarriage. Right. So there are different kind of pregnancy losses. It could be a very early pregnancy loss where only pregnancy test or beta HCG come positive and there is no pregnancy sac after that. There could be a sac seen with no heartbeat or no fetal pole in that. There could be an early pregnancy with heartbeat and after that you lose the pregnancy. And there could be a very late pregnancy loss which happens in the second trimester, like around 16, 18 or 20 weeks. So different kind of miscarriage will have different etiology. Like late pregnancy losses usually have a uterine factor. That means pregnancy was all right, but uterus was not able to hold the pregnancy. So whenever a patient comes like that, we take the detailed history of their pregnancy loss, we ask for the past records, and then we investigate what is required, and we make a personalized treatment. Like you cannot throw a blanket therapy to each and every patient who has miscarriage because nature of miscarriage might be different.
That's so important to understand the underlying cause. But also, doctor, once the cause is determined, what are the best fertility treatments available for someone with multiple pregnancy losses? I'm sure the couples who come are so distraught and I can't even imagine what a feeling it is. And they must be so battered and bruised. So when they come, what are the fertility options that we are?
See, it depends on the cause. Let's say if it is a uterine cause. So we have to do a hysteroscopy. It's an endoscopic surgery where we put a camera inside the uterus and make uterus ready for it. There could be a uterine anomaly. That means uterus has a septum, or sometimes because of repeated miscarriages, they may have adhesions and infection inside. So these also can cause into further pregnancy losses. So first is uterus needs to be ready. It has to be corrected. Second is there could be immune factors. So if patient is antibody positive, so there are certain medicines which are available. It could be immunomodulators. It could be local immunosuppressants, or there could be certain targeted therapies for those patients like ANA positive. These kind of patients, we treat them first and take them for the treatment. Then as we discussed earlier, the majority of the cases, it is the embryonic factor where the embryo may not be capable of implanting or resulting into a live birth. So somewhere that pregnancy is lost because the genetic makeup of the embryo was not appropriate. That's when IVF plays an important role. We create embryos through IVF. We test them genetically. If they are appropriate genetically, the technical term will come as a euploid embryos. That means chromosomally they are normal. So such embryos, if we transfer back to the uterus, so this entire process required IVF. And if these embryos are genetically normal, the chances of implantation, that is success as a pregnancy positive, is very high, and chances of them not aborting and resulting into a live pregnancy is also very, very high.
Many people assume that, IVF is only for the ones who are unable to conceive naturally. There's a misconception that if you're not able to conceive, IVF is the way. But can IVF it also be a solution for couples who are experiencing multiple pregnancy loss?
See, there are a lot of myths about IVF. The biggest myth, people think that IVF is a last option and we should go when it is very late.
Right.
So whenever you need a help from fertility specialist, you coming in time gives you a better success rate. Then the second question is those who are conceiving naturally, and if they are not able to have a live birth, that means somewhere they are losing pregnancy. These are the candidates who need IVF because IVF can help them in achieving a live birth by checking the embryos. So IVF definitely has a role to play in the recurrent pregnancy loss patients.
All right. And hormonal imbalances like progesterone or thyroid disorders are often linked to pregnancy losses, right? So can you explain their role and how they affect pregnancy outcomes? Basically, hormones and what role do they have to play?
See, thyroid is like a basic hormone. So once we are planning for pregnancy, our thyroid level should be under control. There are two types of thyroid disorder. One is where the thyroid gland is working less, that is hypothyroidism. Another is a hyperthyroidism where it is overworking. So anybody who is planning for pregnancy, even if they don't have pregnancy losses or IVF failure, their thyroid hormones should be under control. They help in a better outcome. Hyperthyroidism can sometimes lead to pregnancy losses also. Then comes the role of sugar control. Sugar control is also very, very important because it provides an appropriate environment to the embryo, developing embryo, and resulting into the good outcome. Then third and most important is the progesterone. See, we should not forget the body physiology. In a normal pregnancy also, when egg grows, it releases and that follicle turns out into a corpus luteum. Corpus luteum is nothing. It secretes progesterone. Progesterone helps our body to establish the pregnancy and retain the pregnancy. There are certain patients where there could be a progesterone deficiency, or we call it as a corpus luteum deficiency. So when we are talking about the treatment, fertility treatment, we always make sure that we provide adequate progesterone supplementation and look for the treatment. So when there is a treatment, usually progesterone is given and it is taken care of. But if progesterone is inadequate in the body and there is a luteal phase insufficiency, what we call it, it can result into abortions.
Oh, so should couples actually consider immunological testing if they have a history of miscarriages? Does that help?
Yeah, definitely. So there are various types of immune reaction in the body. See, basically, if we again understand, uterus is regarded as the most sanctum sanctorum kind of place. Because it is the only place which has ability to accept anything. If we look for the embryo, half of an embryo is from husband's genetic or his husband's expression. So that means half embryo is a foreign object to us. Anywhere in the body, it does not have capacity to accept any foreign tissue. Uterus has a magical capacity to accept anything. Even if we put a donor egg or donor embryo, uterus will accept. Okay. In few patients, see, pregnancy, how it happens is there is a mild immune reaction, but when there is a toxic immune reaction, so there is a fine balance between mild immune reaction is required for the implantation of pregnancy. Toxic immune reaction result into pregnancy failures. So there is a word called immunomodulation. That means you have to balance the immunity. You cannot 100% suppress the immunity to get the pregnancy. The pregnancy will not happen. And you cannot allow that toxic immune reaction which is happening in your body to flare up. Then the pregnancy loss will happen. So the entire treatment revolves around immunomodulation. That means detecting if autoimmune antibodies or other antibodies are present, and depending on the nature of the antibodies, plan your treatment. So investigation will be like APLA, ACLA, lupus anticoagulants, ANA. There are multiple type of antibodies, and in few patients we do even HLA typing also.
Okay, so all of these testings are just to determine whether your uterus is able to sustain the pregnancy or not, and
Yeah, our immune system is able to sustain the
or not.
pregnancy.
And all these interventions are made to make that environment most suitable for the embryo to thrive.
Yeah, immune friendly, we could say. So immunomodulation, that treatment is all making the environment immune friendly. And there is one more thought process which is coming nowadays is about, earlier we always used to think that uterus is a sterile area, means there are no bacteria there.
Right.
We all know about the skin bacteria, they are friendly bacteria.
Correct.
So you may not have an infection, but there could be a dysbiosis. Dysbiosis means imbalance between friendly bacteria and a pathogenic bacteria. In our intestinal symptoms also, we have friendly bacteria which keeps us healthy. So whenever there is an imbalance between friendly bacteria and pathogenic bacteria, that means friendly bacteria have reduced. So it can also cause infertility and abortion. See, most of the reproductive hormone, they are metabolized in the liver, then they come into the gut, they get reabsorbed in the body, and in between pathway, these our friendly bacteria metabolize or change them to the required kind of substances.
Right.
So whenever these friendly bacteria are lesser in number, we can suffer from hormonal disorders as well. And whenever in the uterus there is a dysbiosis, that is imbalance between friendly and unfriendly bacteria, it could result into a pregnancy loss.
Right.
And the maybe pregnancy not happening.
All right. So despite these medical interventions you've told us about, that the uterus not being the best environment and all these immunological factors, despite all the interventions, what are the lifestyle changes that somebody can make, such as diet, exercise, or stress management, that can actually improve a couple's chance of having a healthy pregnancy? Because we know all the medical interventions, but what can a couple do from their side to actually help their pregnancy journey?
No treatment can replace the lifestyle management.
That's true.
So lifestyle management would always be the first line of management, provided couple is ready to do that. So in that, most common things come like smoking, then having too many cups of tea or coffee like caffeine, if they are taking alcohol or any other thing. Then we must not forget, our body is in the circadian rhythm with the sun. So many people have that kind of lifestyle. They wake up whole night, they sleep whole day. Even our hormones, they are in synchrony with the sun. So getting up on time, sleeping on time is very, very important. Then the stress. In today's time, there is everything available to us, but the stress is there. Stress can do anything. And what it does, it is very difficult to measure. There is no blood test to measure your stress, and there is no way we can measure what stress is doing for you. So if you believe in some kind of yoga, meditation, or sometimes in our clinics, what we do, we connect them to the patient. Like suppose a patient has 4 early pregnancy losses and they have a successful pregnancy with us, we connect these kind of patient to the successful patient, and this itself, that reduces their stress. Then the third thing is about the weight. Obesity is very common, and obesity disturbs our environmental hormonal milieu in our body. Right. So there are a lot of hormonal disturbance happen. So suppose if we are thinking our oocyte quality could reduce, in men it could reduce the sperm motility. So then shedding of that weight in a healthier way. And when we spoke about these good bacteria, you'll be surprised to know that these good bacteria also need good food.
Good food.
If you eat junk food, processed food, or if you change your diet, which was not there from beginning, these good bacteria also will change. They are like species specific, like certain birds sit on certain trees. Like this, these bacteria are also choosy. So your home food, good food, and we call it prebiotic. Like a good food is like, there's no need to take probiotics. That good food only will invite the good bacteria and a good health.
Gut health is, in a way, so important for your overall health also and your fertility also. So diet, exercise, and making the right kind of lifestyle choices can really go a long way to help with your fertility journey. That's, I think, a unsaid rule, and it is the most important thing that people should follow. Doctor, you spoke about how stress can play a very big role in miscarriages also. And you also spoke about how how you could connect the patient with somebody who's had a positive pregnancy, and that really helps. Talking about counseling and emotional support for couples, the struggle, especially in repeated miscarriages, can take a huge emotional toll. Are there any specialized clinics, support groups, counseling services available for a couple that are facing these challenges?
See, one is there are random support groups online, which you have to search on your own. But I'm very glad to be associated with Nova. They have recognized these kind of need long back. So in Nova, we have separate counselors, which are psychological counselor. They connect to the patient. We ourselves, we counsel or we consult the patient in private chambers and spend a lot of time with them. And we identify the couple who need more and more support, and we connect them to our counselors vertical. There's a separate vertical. So each patient we allocate counselors, and then they identify what kind of counseling they need. And as I spoke, they even conduct these kind of exercise that they connect to them the patients who have positive outcome in a similar kind of situation, which gives them hope. And I think hope is a therapy for the stress. And I can tell you by my experience, it's a very simple thing to know how much stress can cause. Like these kind of repeated loss patient or repeated IVF failure patient, once they get one live birth, second baby, even if they don't want it, just come like that. They don't need any treatment for. So that is an indirect evidence that how much stress plays a role
in today's life. I think stress plays a major role in driving anything in our lives. But you're so correct that, once they do have a live birth, I think the second baby just follows because of the positive environment, and the body is also ready according to that. So, doctor, what would be the next steps if IVF also fails? For couples who've undergone IVF but haven't seen success, what are the next steps for them? I mean, how many embryo transfers should actually one consider before moving to advanced IVF treatments?
See, normally, suppose if a couple comes to us and they are first timer IVF, we do the basic investigation and do an IVF for them. But if two good embryo transfers have failed for them without any documented cause, like we know uterus is healthy, those embryos were morphologically good enough, means in an initial phase, we just see the embryos, how they are dividing.
Right.
So if they are dividing well, they are looking well, we transfer them. So in spite of that, if two good embryo transfers have failed, then we go for the advanced investigation. So in that, there are two things. One is you have to investigate embryo. Another is you have to investigate the endometrium. So endometrium is nothing, it is a lining of the uterus. If endometrium is thin or it is kinked, there is a polyp or something, then you do a hysteroscopy analysis, which is again an endoscopy, and if there is any need for correction, you do it. Otherwise, most of the time to look the endometrium or the uterine lining would be appropriate. But again, if we go back to the physiology, endometrium has to receive the embryo. So in a very simple words, if I say, when the embryo comes, there is a time, there is an implantation window. There has to be certain changes in the environment of the embryo. So there is a genetic signature for that, microRNA, all those things. So which could be identified with the advanced test, which is known as ERA, endometrial receptivity assay. Sometimes I spoke about the infection and the dysbiosis, that the bacterial environment of the uterus is not appropriate. So there are even advanced tests which can check for the chronic endometritis. If there is any infection, there is a dysbiosis, and what kind of antibiotic therapy if required, or what kind of therapy we need to give. So these are pertaining towards the endometrium lining and the uterus. And the second important part goes towards the embryo. So initially we have transferred embryos looking at their morphology, how they look, how they divide. So we call it morphokinetic parameters. In spite of putting those embryos, if they are not implanting, it's a time to check them genetically. Because as I said, even in younger couple, nearly 50% of embryos are abnormal. And this is not fixed ratio that every second embryo is normal. It is a probability. So maybe every time we are transferring the embryos which are genetically abnormal. So you do an IVF, create embryos, but do test them genetically before putting them next time. So you're ruling out uterine factor, you're ruling out the embryonic factor, and obviously you have to look for systemic illness. And as I said in the beginning, the pregnancy loss and the IVF failure etiology is almost similar. So we have to look for those immune tests, we have to look for blood clotting factors, systemic illness, everything we have to investigate and see.
That's very important, the whole investigation. And doctor, is IVF only for couples who can't conceive naturally? I'm coming back to this question again because you mentioned how the embryo sometimes could be abnormal. So can you tell me a little bit about how couples who can conceive naturally but should go for IVF as their first line of treatment also?
See, it has a multitude if we think beyond the pregnancy losses. So in today's era, life is changing. So we are getting now a lot of couples who can conceive, but they don't want to conceive. So they are doing an IVF, freezing embryos, and they say we will come back after 3 to 4 years and plan your pregnancy. But the only thing they are scared of the age. So suppose today lady is 32 years, 4 years later, maybe she is 36, 37 years. So that is one indication. They may not need those embryos, but it is a planning they do. That is one indication. Another indication is, as you said, like suppose there is a genetic illness in the family. They can conceive naturally, but they have to bear the natural incidence of having a diseased child. Suppose somebody, husband, wife are thalassemia carrier. So there is a 25% incidence, they may have a thalassemic baby. So only way to make sure that their baby is healthy is to do an IVF and do specific test on embryos. Otherwise, they have to take a natural risk, what comes in their way. Third thing we have discussed in detail about the recurrent abortion cases, where some pregnancy is happening, but they are aborting, then IVF. And another thing comes is, suppose husband and wife are all right, but the baby has some kind of structural anomalies. And when you evaluate those babies, there could be a genetic syndrome. There could be a genetic syndrome. And that genetic syndrome sometimes has a risk of repeating again in the subsequent pregnancy. So if we have identified those genetic or gene defects in that baby, then probably for subsequent pregnancies, we could detect it before and then transfer the embryo.
What a marvel science is that you're able to do all of these testings and understand so that you can give your baby a healthy life and live a healthy life yourself. Thank you, doctor, for so much insights into why pregnancy losses occur and what can be done and what can a couple do to navigate the journey of miscarriages.
See, this is the biggest achievement of being a fertility specialist. When you see smile and a twinkle in their eyes.
That's great, doctor. Let's talk a little bit about the success of IVF. What is the success rate like? How do we calculate it? Is it 100% successful?
No, that is again when we talk about myth. People think whenever we go to IVF specialist, there will be a pregnancy. And whatever age and whatever time we go, there will be 100% pregnancy rate. So IVF doesn't have 100% pregnancy rate. Okay. And the success rate of IVF is very, very much related to the female age. Why we talk about female age more? Because in today's time, that is a deciding factor. Right. Our majority of patients are coming between 37 to 42 years of age, which was never there before. So the success rate is lesser in them. as per the younger age group, then there are multiple parameters. It could be a low sperm count, it could be multiple systemic disorder, what they have taken treatment before, how healthy is your uterus, how is their general health, and again the immune factors.
Right.
So we cannot say that one success rate is for all, but in general, depending on the clinic, IVF can give you a success rate between 50 to 70%. It depends on the clinic to clinic. And it is the per embryo transfer success rate when we talk about. Suppose somebody has done an IVF and we got more than 2 embryos or 4 embryos.
Right.
So it is calculated as per embryo transfer. In our clinic, we put either 1 embryo or 2 embryos. That means extra embryos are frozen. So maybe one IVF cycle, if you calculate the cumulative pregnancy rate, that means what happens after all embryos being transferred, maybe it is still higher. So it is calculated always per embryo transfer.
All right. On that note, doctor, can you give us a case study, your favorite case study that you would like to discuss? What drives you to keep doing what you do? Something that you would like to discuss with us?
Yeah, so especially I'll talk here about the recurrent pregnancy loss patient. These are the patients because they have seen the pregnancy and they lose that pregnancy. That distress is so much high that sometimes after one abortion, it takes them forever to come back to us. So that's where the communication is very, very important, and more than communication, to connect with them emotionally. So I had one patient, they had 4 abortions. All were very, very early abortions, like somewhere between 6 weeks to 8, 9 weeks, where in a few of the abortion there was a heartbeat, there was a pregnancy loss, there was no heartbeat. So 4 pregnancy losses is like something it's very difficult. And they have come, I practice in Koramangala, they have come from the extreme north of the Bangalore. I asked them also, why did you come? No, another patient has recommended you. They said they have a successful pregnancy with you. We won't go anywhere. How many times you call in a day also, we will come. So then we explained them, explored her uterus, did an IVF, did a PGT analysis of embryos. I got 2 healthy embryos. I transferred only 1 embryo. It resulted into a pregnancy, of course, a healthy pregnancy. Sometimes these patients will have weak uterus because repeated abortion, repeated surgery on the uterus. So only the intervention extra we did in pregnancy was we put a cervical stitch. And I still remember the day they delivered, the man came with the baby, he touched my feet and he said, "Doctor, I cannot forget you throughout my life." So that makes our day and our life.
That's really beautiful. I mean, after having gone through so many miscarriages, when they finally have their baby, their bundle of joy, that happiness might not know any bound. Thank you so much for your time, doctor. Your insights have been invaluable in the field of miscarriages that we've just spoken about. And I'm sure the listeners have so much to take from today. Thank you so much.
It was really lovely talking to you.
Understanding your fertility challenges is the first step towards overcoming them. I hope today's conversation with Dr. Santosh Gupta has given you the clarity and the confidence to take the next steps. If you're looking for expert guidance, the team at Nova IVF is here to help. And if this episode resonated with you, don't forget to subscribe and share it with someone who might find it helpful. Thanks for tuning in to Fertility Tales. See you next time with more expert insights on your journey to parenthood. This is Simrat signing off. Thank you so much.